Over to you, doctor.
Yeah. Let's start.
Yes, sir. I'm ready.
Good afternoon, doctors. Welcome you to this experience sharing program on managing PPH, case studies from labor room, the experience with Carbetocin. Today we have got Dr. Harsha Chaudhary, honorable speaker for this webinar. This program is brought by Hetero Healthcare. Hetero Healthcare, as you all know, has got 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in the portfolio, and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products in market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antiviral, offered oseltamivir, favipiravir, and remdesivir, for which Hetero Healthcare received Award of Pharma Excellence in August 2020 for COVID drugs. Today's program, experience sharing with on PPH, we have got Dr. Harsha Chaudhary with us. Madam is MBBS, MSO Obstetric Gynecology, FRM DMS, FMS, and fellow ICOG with Jeevan Jyoti Hospital. Welcome, madam, and over to you for case
Yes.
sharing. Yes.
Okay. Thank you. Thank you so much, sir, for giving me this opportunity. I thank whole team of the Hetero Healthcare. So today we'll be discussing about the postpartum hemorrhage, which is indeed very common, which we still face nowadays in India. So can we proceed, sir? So postpartum hemorrhage, this is really first slide, please, sir. Hello.
You wanted this one or this one?
Yeah, this one. Okay, sir.
Okay.
So postpartum hemorrhage, this is a daunting event in any delivering patient. So what do we mean by postpartum hemorrhage? This is basically the loss of at least 500 ml of blood following the vaginal delivery or 1000 ml of blood following the cesarean section. And nowadays, if it is more than 1500 ml of blood following any cesarean hysterectomy. So it was basically an old definition. Nowadays, any amount of blood loss which leads to hemodynamic instability in the patient, that amounts for the postpartum hemorrhage. So this is very common nowadays. And even if we take all the precautions, it can even occur in the women who are not at the risk. It is a leading cause of maternal mortality in India and in all the developing countries. And it amounts for nearly quarter of all the maternal deaths globally. Hello.
Yeah.
So this is very much common in the developing countries. It is the leading cause of the maternal mortality, which accounts for nearly 35% of all the maternal deaths. And the maternal mortality ratio in developing countries, it is 240 per 1 lakh live births, which is very much high as compared to the developed countries, which is only 16. And 14 million women suffer from PPH globally. Incidence is reported as 2 to 4% after vaginal delivery, and it is slightly higher, that is 6% after the cesarean section. And in India, the 25.7% of global deaths take place in India, and two-thirds of these attribute to postpartum hemorrhage. So India has a really unexpectedly high maternal death ratio, which is 540 per 1 lakh live births. So what is the etiology of postpartum hemorrhage? We have been studying it for many years, like there are 4 T's, which stands for tone, thrombin, trauma, tissue. So most common cause is the uterine atonicity, and after that come the retained tissue, and the third most common cause is trauma, and the last one is because of the coagulopathies. So basically, tone stands for the uterine atony. When the uterus is unable to contract, it may lead to continuous bleeding. Then when there is the retained tissues of conception, retained products of placenta or abnormal placentation, that is the second most common cause for the postpartum hemorrhage. Third cause is trauma. It can be the uterine trauma, cervical trauma, perineal lacerations, broad ligament hematomas. Can be the trauma of the lower genital tract as well as the upper genital tract. Then comes the coagulopathies, which includes the DICs and all the hemophilias, von Willebrand disease, etc. So what do we find? What are the clinical findings in PPH? So basically, when the PPH occurs, patient goes in shock, and we can categorize the shock in 4 degrees, like compensatory shock, mild shock, moderate, or the severe amount of shock. So the amount of blood loss, we can categorize the shock. Like when the blood loss is 500 to 1000 ml, it is compensatory. When it is more than 1 liters, it is mild category of shock. And when it is between 1.5 liters to 2 liters, it is moderate shock. And when the blood loss is more than 2 liters, it comes under the severe shock. And we find the blood pressure changes, like there is decrease in the systolic pressure, and when there is slight fall, we called it mild. When there is marked fall, like 70 to 80 Hg of systolic blood pressure, we call it moderate shock. And in severe shock, the systolic blood pressure falls down to 50 to 70 milliliters of mercury. And symptoms and signs are, initially the patient feels dizzy and the pulse rate increases, that is the tachycardia. And with increasing amount of the blood loss, patient can even collapse, and anuria happens in the patient. So, and what are the clinical findings? We find the abdominal tenderness, there is circulatory collapse, all the vitals become unstable. We can find the increasing abdominal girth of the patient because of the increase in the uterine size. There is loss of uterine contractions, vaginal bleeding we can see. So these all are the clinical findings which, when we see this in the patient, then we totally suspect about the PPH. So how do we diagnose? Whenever we see the patient of the PPH, we should diagnose the etiology, as well as we should, at the same time, we should start the resuscitating the patient. So initial evaluation is about, we should rapidly assess the status of the patient, whether there is presence of the tachycardia or hypotension, assessment of blood loss, the amount of blood loss we can assess. And we have to assess the entire genital tract for lacerations, hematomas, and signs of uterine rupture. And we have to manually examine the patient for any retained products of conception. And we have to check for the tone of the uterus, whether it is contracted or not. And we have to evaluate the uterus for the uterine inversion. And we should definitely send all the blood investigations of the patient, CBCs, hemoglobin, hematocrit, platelets, D dimers, fibrinogen, RFTs, LFTs. So these are really very important things which we should start after diagnosis that the patient is having a PPH. So this is the approach towards the postpartum hemorrhage, that when there is a poor uterine tone, we can clearly assess the patient is not getting the good uterine tone by palpating the abdomen of the patient. When we find the uterine fundus is above the normal level, then when we feel that the uterine fundus is above the umbilicus, it means that the uterus is not contracted well. So we have to send all these investigations, blood investigations, and we also have to get the abdominal ultrasound for any intraperitoneal bleeding, or for checking the tone of the uterus. And we use many uterotonic agents nowadays, such as oxytocin, prostaglandins, and algate alkaloids. Then second most common cause is tears or trauma. So we have to properly inspect the patient. We have to locally examine the patient. And for if there is any vaginal laceration, cervical tear, broad ligament hematoma, uterine rupture, inversion, or any perineal lacerations, and any extragenital causes in that case. And if there is any retained tissue, like retained products of conception or placenta, we have to manually evacuate that, or we have to gently suction and curettage that, so that uterus can get its normal tone. And if there are any coagulopathies, then we have to initiate these factors like factor 8, fibrinogen, plasma, we all, or in the blood replacements, we all have to do this suddenly. Next slide, please, sir. So use of uterotonic agents. So nowadays we are practicing the active management of third stage of labor. So in that active management, the use of uterotonic agent. So basically this is the oxytocin that is 10 units IM at the delivery of the baby. And cord clamping should be delayed up to 1 to 3 minutes. And there should be controlled cord traction while delivering the placenta. So we have to use the uretrotonic agent at the crowning of baby's head or at the delivery of anterior shoulder at the end of the second stage of labor or following the delivery of placenta as well. So we can prophylactically use them in the prevention of PPH as well as for the active management of third stage of labor. And we can therapeutically use them when the PPH actually happens to the patient. So these are the molecules which we use. Oxytocin, we all know. Then carbetocin, it is not the synthetic analog for oxytocin. Then ergometrin, that is the methergin, which is alcohol. Then there is symptomatrin, which is a combination of 5 international units of oxytocin and 500 micrograms of ergometrin. Then there comes the piezoprostol, which is another prostaglandin E1, which hello.
Hello. Yes, madam.
Next slide, sir, please. So previous slide. Okay, next slide it is done. So today we will talk about this molecule that is carbetocin, which is a next generation drug for PPH management. So this is a synthetic long-acting analog for oxytocin. Therapeutic indication is for the prevention of the postpartum hemorrhage due to uterine atony. And what are its benefits? That basically it prolongs the half-life. Oxytocin usually have the half-life of about 15 to 16 minutes. And this carbetocin, it is having the half-life of 40 minutes. And also the enzymatic degradation is very, very less as compared to oxytocin. So there are many clinical evidences and trials which have proven the efficacy of carbetocin over the oxytocin. So this is a brief description discriminating between these two drugs. Oxytocin is naturally occurring posterior pituitary hormone. It has characteristics like vasopressin, that is the antidiuretic hormone. And carbetocin, on the other hand, is the long-acting synthetic analog of oxytocin. It binds to the oxytocin receptors in the uterine smooth muscles, which results in the rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. So we can use both the drugs in IV as well as the IM manner, but IV we should not use them as bolus. So basically, when we administer oxytocin IV, the peak action comes after 30 minutes. While in carbetocin, we see that the peak action comes within 2 minutes, and that lasts for about 60 minutes, which is very, very high as compared to oxytocin. And when we instill the oxytocin intramuscularly, it has slower as onset of action, but it remains for at least 60 minutes. While in case of carbetocin, it remains for at least 2 hours. So there is clearly this is because of the difference in the half life of these two drugs. Oxytocin is having the half life of 3 to 6 minutes, while carbetocin is having the half life of 40 minutes. And another advantage is that oxytocin, we can only use that, we have to refrigerate at temperatures 2 to 8 degrees Celsius. But carbetocin, this is heat stable carbetocin, we can easily keep them in room temperatures, which make this drug very, very compliant with the uses. So yes, for induction of labor and for augmentation of labor, we are using oxytocin in that. Carbetocin is not for that. It is only for the prevention and the therapeutic management of the PPH. So this is a WHO champion trial, which was conducted by the WHO Department of Reproductive Health and Research. So it stands for Carbetocin hemorrhage prevention. And the objective was to compare the effectiveness and safety of the investigational heat stable carbetocin to oxytocin in the prevention of PPH after the vaginal birth. And 30,000 women were enrolled in this program. So the primary outcomes were the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1000 ml. So what we found in this study was that the frequency of the blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior to oxytocin, and the use of additional uterotonic agents interventions to stop bleeding and adverse effects, it did not differ significantly between the two groups. So carbetocin was nowhere inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So this is a Cochrane review which suggests that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. With oxytocin, we always have to use some or other uterotonic agents, but that is not the thing with carbetocin. So it is associated with blood less compared to symptometrin as well, and it is associated with significantly fewer adverse effects as compared to other uterotonic agents and oxytocin. So these are the guideline recommendations. So all the recommending bodies like WHO, SOGC Canada, RANSOC New Zealand, FIGO, and Swiss body from Germany, Austria, as well as the France, all recommends carbetocin today for PPH prophylaxis. WHO recommends use of any one uterotonic agent among these, while rest of the developed world, the developed countries, they are now recommending the carbetocin as the first line choice for the prevention of PPH.
Your experience about use of drug.
Yes. So, sir, I have been using carbetocin for now for at least 6 months now, and I have
Okay.
really seen the very good results with carbetocin. Earlier, when we were using oxytocin, it is also a nice drug, but subsequently,
Correct.
we had to use the misoprostol, the prostaglandin, carboproc in vaginal
Voice is
delivery
breaking, madam. Voice is breaking.
as well as in cesarean sections. The amount of PPH has drastically reduced in my hospital.
I mean, we are unable to hear in between. No, the voice was dropping. I mean, yeah,
So avoiding the PPH. Yes, sir.
we could not hear in between. The voice was
Hello.
breaking, dropping. Yeah, we could not hear in between. So can you please repeat for the benefit of audience?
Hello.
Hello, hello. Can you hear us, madam?
Now am I audible, sir?
Yeah, now you're audible. Can you
Okay.
please repeat, madam? Yeah,
So I have been using the audio. Yes, yes, yes.
yes.
Yes. My hospital, and the results which I am seeing are really, really amazing. Previously, with the use of oxytocin, we had to use the other uterotonic agents as well. We had to
Correct,
use the
correct.
misoprostols, carboprost, as well as methergin. But now, with the installation of this drug, the PPH incidences has really come down, and we don't have to use the other uterotonic agents with this drug now.
Oh, that's good. Do you
So
use it
the
routinely in all
incidence of
patients?
PPH is really, yes, sir, routinely now I am using routinely in all the vaginal deliveries as well as the cesarean sections.
Yes, sir. And you use intravenous form or
And I'm
intramuscular?
really getting the very good results with this drug. Yes, sir.
Any ad- any adverse effects you have seen, madam, in your practice with this drug?
No, sir. No adverse effects. Up till now, I haven't seen any side effects of
That's
this drug.
great. That's a few questions which came from the panel. I'll just
Yes,
run through
yes.
them. What patient profile? What is the patient profile where doctors can anticipate PPH?
So we can anticipate PPH in patients who are having the advanced age, who are multiparous, and with the overdistension of uterus, such as the twin pregnancy, diabetes,
Correct.
macrosomia,
Fibroids also. Yeah,
or
fibroids.
polyhydramnios, and where there is precipitate labor or when there is prolonged labor. And so, in severely anemic patients or in preeclampsia, in all these patients, we can anticipate that the chances of PPH are increased.
And even
So
in
there
fibroids
we
for that matter.
Yeah, in
Yeah,
fibroids, any Mullerian
fibroids.
anomalies, placenta
Yeah,
previas, abruption in all these
correct.
patients.
Acha, even in placenta previa we can expect.
Yes, sir.
Good. In which patients would you prefer to use carbetocin over oxytocin? Of course, you have to give us this answer. You are using carbetocin in all patients now.
Yes, sir. I am now almost using in every patient.
Very good. Can you, your experience, madam, can you use carbetocin in case of retained placenta? Of course, after removal of placenta.
Yeah,
Any
obviously,
experience you
of
have?
course, first we have to rule out that there should not be
Yeah,
any
correct,
retained products. But if there
correct,
is
correct,
retained
correct,
placenta also, because carbetocin helps in the physiological contractions of uterus.
correct.
It is unlike methergin, which cause the
Mhm,
hourglass contractions. And so, in
mhm.
case of methergin, we cannot use this in the retained placenta, but carbetocin is safe in for use in the cases where they are retained placenta as well, because it causes
Placenta
the
plasma.
physiological contraction of uterus. That's why.
Did you have any experience, madam, using in these cases?
So not particularly like in retained, whenever there
Okay.
is retained placenta, so obviously we'll first remove the placenta
Remove
manually.
the placenta. Yes, 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 yes,
But
yes.
we do it simultaneously, that we are removing the placenta
Correct,
and
correct, correct.
we have also started the carbetocin. So yes, we can
Carbetocin.
use.
And in case of RH negative mothers, which is a big thing in the
Yes, that there is
interiors,
RH negative mothers are not a contraindication for the use of carbetocin.
contraindication.
No.
Now, many doctors use oxytocin for induction. Can they use carbetocin for prevention of PPH?
Yes, sir, because oxytocin half-life is only 15 minutes.
Okay, so
And
by
when
then
we use
the
the
half the
oxytocin for the labor induction, the proper labor will take time, then the delivery happens. So yes, we can safely use the carbetocin for the prevention of PPH in such patients
by
as well.
then oxytocin effect would have worn off.
Yes, sir.
By then oxytocin effect would have worn off because of short half life.
Yes, sir.
Yeah. But by the way, have you seen any ADH type of side effects with the carbetocin, which sometimes happens with oxytocin?
Yes, sir. Because with high doses of oxytocin or
Correct,
when we
correct,
use
correct,
it IV bolus, we generally see the
correct,
delusional hyponatremia in the patients because of the
correct, correct,
hypertension.
correct, correct.
But that is not seen with this carbetocin
Carbetocin.
drug,
That's what I was
because this is a
thinking. Yeah,
synthetic analog and it is not
yeah,
having
yeah,
that
yeah, yeah.
antidiuretic properties
Adverse
like
effects. And
oxytocin.
you generally prefer IV route or IM route or both routes you
So
use?
generally, I prefer IV route, that is the
IV
100
route.
micrograms in 10
IV.
mls of saline, and we give it over two to
Okay.
three minutes because the
A
action
slow
is
IV
immediate.
injection.
Yeah, slow
Yeah.
IV we give it.
Right. I mean, if a patient doesn't respond to carbetocin, additional uterine tonics that you would use, there's a
Sir,
possibility. I mean,
patient
any patient.
Yes, sir. So generally, yeah, use of additional uterotonics is not contraindicated, but generally there is no
Correct.
need for them. But still, if the
Need.
patient is not
Correct.
responding, then yes, we can, first of all, we can use the tranexamic acid, then uterotonics like
Correct.
misoprostol, carboprost, all we can
Yeah.
use. And sir, when the PPH happens, so all drugs have to be used simultaneously.
I mean, yeah, it's an
So
emergency. We cannot keep one running.
yes,
And
sir,
at the
yes.
same time, we have to keep OT ready.
We have to get all all the drugs which
We
we
have
have
to
known
get
so far.
we have to get the entire hospital in that
Yes.
place.
Yes, sir. So yes, but there is
And
no
keep
contraindication
Yeah.
for this.
Use of.
Can
I mean,
use.
you told this. Should carbetocin be kept as a reserve drug,
Sir,
or it
I
should be used
think
at first?
now we should be using this drug as the first line
First line.
PPH prophylaxis because, yeah, this is very, very compliant with the patient. We don't have to refrigerate them, and the efficacy is really very much high.
Yeah.
And the use of other uterotonic agents is not needed, so it is also the cost effective.
Correct.
So
And the
I
best thing
think
is that
it should be
storage
nowadays a
conditions.
first line drug for
Yeah.
the management. Yeah, storage conditions. We can
Storage
easily store
conditions.
them, and it comes in the like first ampule is needed, one ampule is needed. For
And,
oxytocin, we have to get 4 to 6 ampules. So,
and I getting IV personnel for IV it may be a problem in the interior. So we don't have people there. There one injection is
okay.
anytime beneficial. What is the role of an anesthetist, madam,
So,
vis-a-vis the
sir, do you?
anesthesiologist?
Mhm. Sir, role
Yeah,
of
madam.
anesthetist is really very important because there are many drugs which are contraindicated in asthma, cardiac arrhythmias, hypertension.
Yeah,
So, anesthetist
correct,
will have to look for those conditions.
correct.
Like for methergine and carboprost, we cannot give them in the cardiac arrhythmic patients,
Yeah.
hypertensive patients,
Prostaglandin,
RH
yes,
negative mothers
correct,
also.
correct, correct, correct.
So, role of anesthetist comes in that when we have to choose. But generally, we see that carbetocin is generally safe for
Safe.
even in these conditions also.
And finally, to give a message, take home message for our audience on carbetocin.
So take home message is generally one should nowadays try to use this drug carbetocin as the first line drug for the management of PPH. And if the doctor cannot use in all the vaginal deliveries, so at least in all those cases where we anticipate that PPH will happen, all the high risk cases, we should
Correct, correct.
definitely be using this drug, and in all cesarean sections also.
And in your experience,
So
you have not seen any side effects. And we hope we don't see any side
yeah, there are
effects.
no side effects, and
Yes.
this is a wonderful drug. We only have to just give one ampule, and then we can sleep peacefully. Yeah, okay, patient is fine. And literally, I'm not. The incidences of PPH has really decreased in my hospital
Any
once I have started
secondary
using this
PPH you have
drug.
seen, or secondary PPH also doesn't occur after use of carbetocin?
So secondary PPH, like in one patient, I guess I have seen,
Yeah,
but secondary PPH it all because the half life is
they're pretty
more
long.
so
Yes, yeah, yeah.
yeah, pretty long. So
Very good. Yeah,
yes.
right. So what do you use in that secondary PPH? You would use a prostaglandin?
So in secondary PPH, so first we use all the drugs: tranexamic acid,
Yeah,
misoprostol,
yeah, yeah,
prostadine,
yeah, yeah.
oxytocin 40 units in 500 ml. We use
Again,
everything if the
yes, yes,
secondary
yes,
PPH
yes, yes.
happens, and if it is atonic uterus, and then we search for
Yeah.
any genital trauma. It is not traumatic.
Correct, correct, correct,
We
correct, correct.
yes,
It is really an emergency.
yes. So this that is a big emergency.
Really emergency. In my
Yes.
time, madam, just to share experience, when I was in this wards, we had only oxytocin and methergine with us.
Okay, sir. Symptometrin.
So,
I have never seen symptometrin even in
no,
my
no, no,
PG
no,
days.
no.
Not
No,
nowadays.
no, no, no. I mean, we have seen only
No.
oxytocin. But in my time, we had
Uh,
only oxytocin and methergine, bus. And
Methergine.
you know, and then was
Yes, sir.
OT. There's nothing else. Anyway, thank you so much, madam. Thanks for your experience sharing.
Okay.
Thank you. I'm sure the
Thank you
audience
so
must have
much,
benefited. Yes.
sir.
Because
It
you know
was great
the
having
clinical
this session.
yes the clinical experience of doctor gives them confidence now in using. Rather, there may be so many clinical studies, but thank you so much.
Yes,
Thanks marketing team Hitro, thanks sales team for this coordination, and
yes.
thank you Shashidhar for your IT support. Thanks all of you and wish you a very good afternoon. Thank you so much, madam. You can sign off.
Thank you. Thank you. Thank you so much.
Thanks,
Thank you, ma'am. Thank you
Shashidhar.
so very much
Thank,
for accepting and yeah, sharing such nice experience on the management of PPH and overall in carbetocin, ma'am.